Hello. I see Cassandra Johnson as the only other participant. You're muted. Still waiting for Carmen or Courtney. This is Sean Kelly, the presenter for today. Test 1, 2, 3. Test. Can you not hear me? I know you're on mute, Cassandra. And I see the microphone with my name seems to be reading my voice fine. Cassandra, are you then operating the slides for me today, or is Carmen? Okay. I'll wait for Carmen then. There's Courtney. Hello, Courtney.
Hi, good
Uh,
afternoon. Hi, good afternoon.
Good afternoon. Will you be operating the slides or is Carmen doing that?
Yes, I'll be moving your slides for you.
Okay, great.
Carmen should be here in a second.
Okay. And I sent her the updated slides yesterday or the day before. You got those, I'm assuming.
I don't think I was on that email.
Yeah, I did not.
Okay.
I didn't include you. I realized that after I sent it, but it was such a large file size. It took a while for it to be sent. So I just assumed Carmen would forward it to you.
Yeah, I will ask her to send.
Okay.
Okay, yes, I have your slides.
Okay, great.
All right, Carmen?
Hi.
Hi. I was just reading your email.
Carmen, could you give me, I guess, panelist or host privileges so I can share my screen for Dr. Kelly? Or co-host, if you can do co-host.
Sure. I'm not seeing the button.
If you open the participants panel, and then you'll see my name and then two boxes.
Oh, gotcha.
And then if you click on more, like a drop down should open up.
Okay, so I can make you host. Looks like my option.
Okay. Well, since you're presenting first, just to intro, once you're done, just make me the host so I can share my screen for his slides.
Okay.
So you can keep it, you as the host for right now.
Okay.
How's everybody doing?
Good. How are you?
Doing good.
Good.
Was nice to have some sunshine here recently. So
Oh, yeah. Yeah, I'm still out here in the Pacific Northwest too. It's sunny but cold, but it's nice.
Right. Yeah. Looking forward to spring. Few more
Yes,
days.
absolutely.
Courtney, where are you? Are you on the East Coast or?
I do live in DC, but right now I'm in St. Louis. So we have
Oh,
rain
okay.
right now.
Yeah.
Yeah,
Did you
it's
get
like pouring down.
Did you get a lot of snow this year?
Um, no, not as much as a lot of other places, which I was
Okay.
expecting more snow.
Right.
We did have a lot of freezing cold weather though.
Oh, okay.
Yeah, like below zero temps for
Wow.
probably like 2 weeks or so.
Okay. Caught up with what Texas was experiencing, it sounds like, I'm assuming.
Yes.
Yeah.
Yeah. I think we were better prepared though than Texas.
Yeah. Yeah. I went to dental school in Richmond, Virginia. You know, we were kind of on the cusp as far as winter was concerned and snow. So it was one year we had a pretty good snow and the city wasn't prepared to with the plows and stuff like that. So when it doesn't happen very often, it can be pretty cumulative infection prevalence rate among dentists and far below that of other health professionals in the US, although slightly higher than that of the general population. Next slide. And I would reference from OSHA, this is per the ADA reference in the previous slide, exposure risk levels for dentistry performing aerosol generating procedures on well patients amid this pandemic is high. Next slide. So in collaborative ADHA ADA webinar available on the ADHA website, this COVID-19 prevalence graph is presented. The ADA has dentists at a 2% infection rate, up from 1% in the previous study. And this is unpublished data from the ADA per the legend on this graph. 3.1% for the hygienist, as we previously saw in the study in the previous slides. 2.1% is the general population prevalence rate for COVID-19, and then 11% for healthcare workers. From this webinar, the question was asked, were infections directly linked to the occupation of dental hygiene? Of those testing positive, 38% had contact tracing, and of those, 26% or 14 hygienists reported that contact tracing identified the primary dental practice as a likely source of transmission. Further investigation compared those who did with those who did not practice dentistry during the previous month, both hygienists and dentists. And the rate of COVID-19 infection was statistically the same. So what does that mean? Well, that likely a significant percentage of dental healthcare workers, dentists and hygienists, were exposed outside the dental practice. Next slide, please. The ADA publishes this ongoing research during the pandemic. Per the legend, the darkest blue is closed and not seeing any patients. The shades of blue become lighter as you go from closed but seeing emergency patients only to open but lower patient volume than usual, and last, open and business as usual. What is shown here is nationally, but you can search by state and other categories as well. At the beginning of COVID-19, represented by the very top row, nearly 19% of dental practices were closed and not seeing any patients. 76% were closed, but seeing only emergency patients. And as of the week of February 15th of this year, represented by the bottom row, nearly 43% were open. It was business as usual, and another 53% were open, though seeing lower patient volume than usual. Thus, over 98% of dental practices were open by mid-February. Next slide. This is also from the same ADA website. And by mid-February, 80% of practices were seeing over 75% of their normal patient volume. This is encouraging news for dentistry. Next slide. We at the Northwest Tribal Dental Support Center recently provided our own survey. Next slide. And we show that nearly 73% were reported open to direct patient care. However, in reading through the other comments, this number was actually higher. Of the other 27%, all but one clinic was providing patient care, but chose to indicate other in order to provide more detailed explanation of services. The one clinic that is not is closed due to construction. So in essence, 100% of the clinics surveyed are providing patient care. Next slide. And what services are they providing? Again, the only clinic not providing services is under construction. So more comments regarding services was provided, but note that over 75% of our clinics are doing routine preventive care, and 50% are doing complex procedures. Complex procedures would be those such as multiple tooth extractions, perhaps for preparation for a denture, root canals, crown and bridge. Those would be considered complex procedures. Next slide. Next question was, are you performing aerosol generating procedures? With the one clinic under construction and another responding as other, stating only when patients have been COVID tested in most cases, 100% of our clinics are providing aerosol generating procedures. Next slide. The next question, for providing COVID-19 testing, 81% responded yes, and 19 responded no, 19%. With additional comments, 2 programs stated that the medical department provides the testing, and a third stated, we have the opportunity, but elected against, as we are screening and not treating any patients with symptoms or possible exposure, and rapid tests are not sensitive or accurate for asymptomatic clients. PCR testing with a wait time of up to 72 hours was not a viable option in terms of scheduling. And I would just add to this that this is the general trend in private offices as well. Next slide. We then ended the survey with this statement. Please comment how and when you plan to return to normal in providing dental services. What, if anything, will be different in providing patient care when you return to normal compared to pre-pandemic? And I'll try to share these comments at the end of the presentation as time allows. Next slide. So in determining for your clinic what levels of services you should provide, I would first direct your attention to the CDC guidance for dental settings, which was last updated December 4th, before the vaccine was available. We must recognize dental settings have unique characteristics that warrant specific infection control considerations. Next slide. Note that levels of service require a balance between minimizing harm to patients for delaying care and harm to personnel and patients from the virus. Next slide. The CDC guidance for dental settings has 2 sections for recommendations. One is for routine dental healthcare delivery, and the other is for providing dental care for patients with suspected or confirmed COVID-19. And we'll focus on the first section. Next slide. The CDC guideline has a framework represented here in this table. One needs to consider potential harm if if treatment is not provided, and the degree of community transmission in determining what levels of services to provide. For example, in this table, which I'm only showing the top half for now, the first column is the potential for patient harm, and therefore dental emergencies would fall in the highly likely category. As you move to the right, the columns have decreasing community transmission. The column in the middle or to the right of the examples is substantial community transmission. And then moving left to right, the next column is minimum to moderate community transmission. And then the far right column is no to minimal community transmission. Next slide. Moving down in the column on the far left, an unlikely potential to cause patient harm if care is not provided are those services we would consider routine. And it is these services we wish to move toward in completely opening our dental practices. Next slide. So how do we know our community transmission levels? Well, we should rely on our local health department. Your CEO or health directors will be monitoring your community use using such resources, and which will be key in the decision making for your clinic. There's an example of the state of Washington. These state sites are routinely updated and contain many infographics that pertain to the pandemic. Next slide. And I recommend subscribing to your local health department's updates as well. Next slide. OSHA also provides reopening recommendations. Here we have the level of ongoing community transmission of COVID-19 in that community. The phase of reopening the community in which the dental practice is located has entered, and the risk of dental practitioners and support staff of being exposed to sources of SARS-CoV-2. Next slide. Prioritize patient treatment based on risk assessment is important. Based on urgent needs and those who are emergent, those who likely will have a dental emergency within the next 3 months, treat these patients first. Using the ADA Caries classification system could be a helpful tool in your assessment. And this is available on the ADA website. Next slide. With that said, what is the potential harm of, say, an ICDAS2, the upper right image of the molar tooth, or a D1RA3 lesion, that which is represented on the lower right radiograph? How about using non-aerosolizing procedures, such as minimally invasive dentistry, the use of silver diamine fluoride or a glass ionomer sealant for these patients? Next slide. And per OSHA, PPE recommendations for use of an N95 filtering facepiece respirator does not change between an aerosol generating procedure on well patient and a patient with suspected or confirmed COVID-19. N95s are recommended for aerosol generating procedures. Next slide. And of course, supply is also a key issue for our determining levels of service. N95s, are they still an issue? Here's a CDC link addressing N95 respiratory supplies, and you can use that to help with obtaining more information about your supplies. Next slide. With that, you should know your capacity strategy. This will allow you to take the next steps in determining the services you may provide. Next slide. Those capacity strategies are the conventional capacity strategies, which I believe most of us are in currently, and that is incorporated in everyday practices. Contingency capacity strategies during expected shortages, and then crisis strategies during known shortages. Next slide. Note that crisis and contingency standard should not be used if there is any option or opportunity to return to conventional practices. Once personal protective equipment, supplies, and availability return to normal, healthcare facilities should promptly resume conventional practices. Next slide. And if you are in a crisis capacity, you should know your reuse limitations as well. Realize too, there are very complicated steps in monitoring decontamination methods. Employers should be able to demonstrate effectiveness of any decontamination method used. And I would ask, do programs or practices really have the means to accomplish this? Next slide. In this picture, the N95 actually may not be the PPE of concern, as manufacturing has been able to reconfigure to increase production. Gloves, on the other hand, are more difficult, as manufacturing is not as diversified. Asian control and specific manufacturing makes repurposing factories difficult, as is accessing materials used to make gloves. The pandemic has caused also factories to close, therefore a greater burden on the supply chain. This and the increase in demand has created a global shortage. Next slide. So it's important to know your vendors for masks and other PPE, IHS, state and local emergency management programs, and private companies such as Henry Schein, McKesson, Patterson Dental, and others. Next slide. One of the resources we have available to us is the IHS National Supply Service Center, and here we have the link provided. Next slide. Also available are the instructions for accessing PPE through the Strategic National Stockpile. And this is a one-page document that's available as a resource. Next slide. Here's a list of other armamentarium. One item not listed here, but recommended. Any guesses what that might be? Actually, there are two things. One is four-handed dentistry, which is identified as an important aspect of the dental control of mitigating aerosols. And the other is the rubber dam, also very important. These are two ways of practicing dentistry that may prevent the transmission of the virus. Some of the items we have listed here are the mirrored high evacuation tips, other intraoral suctioning devices such as the Dry Shield, Isolite, or IsoDry, Mr. Thirsty, extraoral dental suctions, and air purifiers as well. Next slide. Updated healthcare infection prevention and control recommendations in response to COVID-19 vaccination is provided by the CDC. Except as noted in updated recommendations, healthcare personnel should continue to follow all current infection prevention and control recommendations, including those addressing work restrictions, quarantine, testing, and use of personal protective equipment to protect themselves and others from SARS-CoV-2 infection. Next slide. And the CDC defines fully vaccinated as a person who is greater than or equal to 2 weeks following receipt of the second dose in a 2-dose series, or greater than or equal to 2 weeks following receipt of 1 dose of a single-dose vaccine. Next slide. And the CDC also provides post-vaccine considerations for healthcare personnel with systemic signs and symptoms following COVID-19 vaccination. Next slide. And the ADA website is a great resource, maintaining updated information covering many aspects to the vaccine. Next slide. The ADA Coronavirus Center for Dentists has frequently asked question fact sheets. Here's one for practice owners. And the next slide. And here's one for the employee dentist. Note that, moreover, we do not yet know how effective or long lasting the vaccine will prove in the long term, or whether someone who receives the vaccine may nevertheless spread the infection to others. Next slide. And I thought this was interesting. It's from the Smithsonian Magazine. It says, in the push to get a vaccine approved for emergency use as quickly as possible, other effects of the vaccines were left untested. Scientists must test a smaller pool of people with greater frequency to understand how the virus travels between people after vaccination, an effort that became secondary to studying vaccine safety and efficacy. Most vaccines still seem to prevent worse outcomes like hospitalization and death against the new variants. However, it may be months before researchers have conclusive findings about how viral transmission from vaccinated individuals to unvaccinated individuals works. Next slide. So remember this earlier slide from the collaborative work of the American Dental Hygienists Association and American Dental Association. And it does show that we can and have been practicing dentistry safely if we continue to follow the recommendations. Next slide. And I would say again that the US dental industry has high standards for infection control. We have for decades. As presented, dental practices have and are using necessary controls to prevent the spread of SARS-CoV-2. So let's please use those resources available to you. Next slide. Okay, so I would like to again go back to the survey from the Northwest Tribal Dental Support Center. And as I shared earlier, we did end our survey with this. Please comment how and when you plan to return to normal in providing dental services. What, if anything, will be different in providing patient care when you return to, quote, normal compared to pandemic? And so I'd just like to share those comments with you. I did break them down into different categories, one being infection control, the other being administrative controls, and a third being engineering controls, and then lastly, other additional comments. So these are the comments provided. All our providers and staff had training in universal precautions. I think that's a great idea that programs revisit what those precautions are with their dental team. And so that's great that clinics are doing that as well. Continue N95 mask wearing during aerosol generating procedures. Hygiene will assume annual cleanings exams, but will work with an assistant. That's something that's different. Generally, and I'm sure all of us could attest to going to the dentist and having our teeth cleaned, that there's not a dental assistant assisting the hygienist. And so practicing four-handed dentistry is a viable option as staffing permits. Staff will continue N95 wearing during all direct patient care and surgical mask wearing among all staff at the time, all the time. New infection control protocols such as wearing surgical caps, donning and doffing of scrubs on arrival and departure of dental clinics. Under administrative controls, limiting how we schedule patients, increased time between patients, greater emphasis on grouping families together for appointment times. I think that's a great idea as clinics schedule patients, bringing all family members into the clinic around the same times will help facilitate more control of our footprint in the clinic when we are scheduling patients. Appointments will stay 1/3 longer than original. Example, a 1-hour operative appointment is now an hour and a half. This will allow the time for screening and cleaning processes, though there is hope that this will be shortened once we get in a rhythm. More comments in staff staggering in mid-April. Many clinics have had to stagger their staffing in lowering their footprint in the clinic. And so some staff would work from home or have alternating work days. And so this clinic is hoping to return to more normal scheduling of their staffing. Continue COVID-19 testing as needed for non-vaccinated patients requiring aerosol generating procedures. Waiting room will remain closed and patients will continue to be screened and greeted in their cars. Engineering controls, having a donning and doffing room, added 7 ISOVAC systems to our operatories to help minimize aerosols. I believe those are the extraoral evacuation systems. Added ultraviolet magnetic plasma filtration filters over our intakes to dental. Opening windows. Upgraded filtration in our room air filtration system. Other comments provided in the survey were, surprisingly, during this pandemic, none of our dental team was affected. We are currently back to normal. We are hoping to return to our, quote, new normal mid-March. 95% of dental staff will be fully vaccinated and bulk efforts of testing, contact tracing, and vaccinating our community will be done. Looking for mid to end of March as more are vaccinated. Hopefully we'll be back to normal in April. We expect to return to normal in the fall of this year when the state and the ADA say we can. Another comment, unknown, dependent on transmission risk and CDC guidance. Another clinic when we have full staff. Another comment, I like to go back fully. No face shields, no walled off rooms, no temperature checks, except continuing to use our extraoral suction equipment since they were spendy and they are expensive. And another comment, we will watch community COVID trends, and if numbers continue to decrease and or remain less than 1% of the population, we will maintain routine service delivery. Just a few more. We are opening still within the guidelines established by the CDC for the pandemic. And my assumption is that in a lot of ways, this is the new normal for the foreseeable future. Another comment, I don't think the additional precautions we have adopted will be going away even after the COVID-19 pandemic is more or less contained. And the last comment I'll share today is we plan to keep operations as is for the foreseeable future. We have an open bay floor plan, so we will continue to only see one patient at a time. So those were the comments from our survey. Kind of gives an idea of where we are at as a community in Indian country. You know, we certainly do rely on the resources available. The CDC was mentioned a number of times, the ADA. And so we're grateful for the information that is provided there. Certainly our local health departments are very useful as well. So with that, we can go to the next slide. And I just want to say thank you for this opportunity to present to you today. And I am willing to, if I'm able to, answer any questions that you might have.
Thank you, Dr. Kelly. You provided us a lot of great information. Just a reminder, if anyone has any questions, please type them in the chat box. We do have a few just to get us started. Where can people find a summary of the survey that you just went through?
The summary of the survey is not something that we have published or posted, though I would direct you to the Northwest Portland Area Indian Health Board, specifically the Northwest Tribal Dental Support Center. Tycee Mason is our director for the support center, and she might be able, and she was, I believe she's still on this presentation, but perhaps reach out to her and we can go from there.
Hi, this is Tycee.
Tycee.
Hi, great job, Dr. Kelly. I just want to let you know that it is confidential for our area because it states what tribes and what they're doing. So we won't be posting individual responses or what tribes or dental programs provided that. But these slides will be available, and the information that Dr. Kelly provided is, more general information.
Right. Thank you, Tyson.
Yes, just to reiterate, the slides and the recording will be available within a few days on our website. So please be on the lookout for that. We do have another question. Are there a lot of clinics that have walled off their open bay operatories?
I don't know. I know of one actually early on in May, June of last year, that is what they attempted to do. But I don't have any information specifically as to which clinics have done that. We have monthly meetings, dental director meetings. And so just in conversation, kind of get a feel for what people are doing. But I'm sorry, I don't have any data to support how many or what percentage have done that.
What are your thoughts about extra oral suction benefit?
Right. Actually, Dr. Damon Pope in the Portland area IHS has submitted a report, and actually that just came out yesterday afternoon. So I have not read it yet, but he has, my understanding, solicited information to see which of those are, I think, vetted through I want to say the FDA, but I'm not positive. As I said, I haven't read the report yet. And I think that would be our best resource to review to answer that question. So I would reach out to Dr. Pope, and if you don't subscribe to the IHS listserv where that's been pushed out through, then contact the IHS and get that information, or I can forward it to National Indian Health Board, and you guys can maybe disseminate that as well.
Yes, any resources that you want to share with us, we can definitely send those out.
Okay.
Next question. Any sites out there already using EOS?
I'm sorry, repeat that.
Any sites out there already using EOS?
That would be the extra oral suction devices. Yeah, that we were just speaking of. And actually, I believe a fair number. Again, I don't have specific numbers. I would think from Dr. Pope soliciting clinics to provide their input regarding these units. I would suspect that he has a fairly good database to indicate how many clinics are using these. I know we've had in our dental director meetings some discussions in the various issues surrounding using these devices. Talked a little bit about decibel levels and hearing conservation, being an issue. I think in particular, as we are wearing more PPE, the face shields, the N95s, communication amongst staff between the dentist and the dental assistant and the patient, I think, and then adding another level of background noise, if you will, from these units. I know that's a concern. I don't personally use them in our clinic. We fortunately have enclosed rooms that have adequate air exchange and exhaust outside externally of the building. So we were able to mitigate and control the aerosols in our enclosed rooms without adding the need to an extra oral suction device. Plus, throughout our clinic, we have the UVC in our ventilation system and the HEPA filtration. And so we have the appropriate engineering controls as recommended. So we haven't had to extend and purchase these devices. So again, I would refer to that report by Dr. Pope.
Thank you. Are there any additional questions?
Oh, you can go to the last slide. There's one more. I just realized that.
Oh, yes. Oh, there we
There you
go.
go. Yeah, we that's our clinic on the top floor. And early on in the pandemic, some of our staff started putting up these posters and hearts and just an encouragement to patients walking by. You know, we got this, and we're here for you. We're here to provide quality dental care safely, and so far we've been able to do that throughout the year. So I guess I end with that. Everybody's doing it seems to be a great job. We're all kind of learning this together, and we'll continue to do the best we can to keep ourselves, our staff, and our patients, our community safe. So thank you so much again for this opportunity to share with you today.
Okay, if there's no more questions, we will
Hey.
go. Oh, Carmen, do you have some?
Thank you, Dr. Kelly. We just wanted to thank you for your time and thank you for the wonderful presentation. And I am, for everybody, thank you for joining and thank you for everything that you do. I am going to add a link to the survey to the chat. So please, we're happy to hear your feedback about the presentation. Also, if you do come up with any other questions, go ahead and forward that to us. I'll put my email address in the chat and we'll make sure to get that to Dr. Kelly if there's something that you come up with later. And thank you, everyone.
Thank you, Carmen. Thank you, Courtney.
Thank you.